Welcome, everyone. Thank you so much for joining this month's Fireside Chat in recognition of National Minority Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team, and I will be moderating this session today. Thank you all so much on behalf of our team for joining this Fireside Chat. As mentioned, this month is National Minority Cancer Awareness Month, and our goal is to address cancer disparities through awareness and education. Although cancer can affect anyone, not all groups experience cancer equally. So in an effort to prevent, treat, and survive cancer, the multiple inequities that are contributing to the cancer disparities that we see in our country must be addressed. So today we are joined by Dr. Dana Carroll and Master of Public Health student Julie Ntegeye for an important discussion on the current state of cancer disparities in Minnesota and to hear about some of the exciting and impactful research that is being conducted by minority population communities across the state of Minnesota in collaboration with the Masonic Cancer Center. It is now my pleasure to introduce to you all our speakers today. Dr. Dana Carroll is an epidemiologist and certified tobacco treatment specialist committed to achieving health equity through reducing commercial tobacco use. Dr. Carroll's research spans a continuum from analysis of large epidemiologic surveys to clinical trials and community-based participatory research. Over the past several years, she has had the opportunity to collaborate with tribal nations and community organizations serving American Indian persons on projects examining susceptibility to cigarette smoking and lung cancer. More recently, she has been utilizing mixed methods to help evaluate the rich knowledge and expertise of American Indian persons and to develop culturally tailored approaches to smoking cessation. Her other contemporary area of research entails studies that seek to inform product standards on commercial tobacco products. Within this area, she is interested in identifying how to reduce the appeal of cigarettes and has contributed to efforts demonstrating the potential public health impacts of reducing nicotine levels in cigarettes. Dr. Carroll has a strong commitment to community engagement and believes that everyone should be talking about health disparities. She strives to engage and build relationships rooted in trust and cultural humility with American Indian tribes and other health disparity populations throughout her research. Julie is a second-year Master of Public Health student in environmental science with a minor in public and health equity. Julie earned her bachelor's degree in political science and international studies at Iowa State University. She enjoys working with communities and supporting them in fighting health disparities. Julie is a research assistant, and works with Dr. Dana Carroll in continuing to bridge some of the health disparities in the community population, in the minority community populations across Minnesota. And so, as you've just heard, we are so honored and privileged to have them both here today to share more about the incredible work that they are both involved in to address cancer disparities. So we will be recording today's session, and you can refer back to the recording on our YouTube page. And that's going to be at the Masonic Cancer Center's YouTube page at Masonic Cancer Center. For University of Minnesota employees or family members participating in the University of Minnesota's Employee Wellbeing Program, I'm going to put a link in the chat shortly to complete the survey to mark your attendance to earn your wellbeing points. So before we begin, I just would like our audience to get familiar with using the Q&A feature, which is going to be located on the bottom right of your Zoom screen. During today's session, please use the Q&A features to submit your comments, reactions, and questions. We have time carved out at the end for some Q&A. Okay, now without further ado, I'm gonna pass things over to Dr. Carroll and Julie. Please take it away.
Thank you, Amna. And I'm just gonna quickly share my screen. All right, it is such a pleasure to be here today and to be speaking with this great audience. Looks like we have about over 60 people here. So I'm Dana Carroll, and it's great to be here with an audience and to be here with my student, Julie, who will also be speaking today. So when asked to do this chat with you all, we had been asked to fulfill 2 agenda items. One is to learn about the current state of cancer disparities in the state of Minnesota. And the other, and one that we're really excited about, is to learn about how Minnesota communities are tackling cancer disparities in collaboration with the Cancer Center here. So we will not have enough time to do the former. So if anybody is attending and really wanting some epidemiological data showcasing cancer disparities, I encourage you to follow up with me. We feel at times that data is often frequently found, and what's less talked about is really how people are addressing the cancer disparities. That's what we're planning to do today.
All right. First of all, I would like to respectfully acknowledge the sacred land upon which the event and the activity of the Great Northern take place in Minneapolis and St. Paul. This is a traditional homeland of the Dakota people, unfairly seized in the Treaty of 1837 and 1851, whose steward is for millennium. The Ojibwe and other indigenous nations have cared for this land as well. All right. In celebration of the National Minority Population Cancer Awareness Month, Dr. Carroll and I wanted to share about some of the rich cultures in Minnesota and hear about some of the exciting and impactful research being conducted by the minority population community across Minnesota in collaboration with the Masonic Cancer Center, University of Minnesota. So thank you for joining us today. All right, so what comes to mind when you read this question? What contributes to cancer disparities? All right, so too often there is too much talk about the individual level and not enough conversation on the multiple level of influence. All right.
Julie, can I just pause you for 1 second? Can you try to speak up, please?
Yes.
Thank you.
Can everyone hear me?
We can hear you. It's just a little quiet.
Okay. All right. So again, this is a motto made and used by the National Institution on Minority and Health Disparities. We like it because it shows that cancer and health disparity in general is caused by much more than just individual factors, but multiple levels of influence, from individual to societal and multiple domains of influence, from biological to healthcare system levels. All right. Well, take lung cancer as an example. Disparities in lung cancer mortality may be driven by genetic risk. As you can see, that's the individual biological. Smoking behavior, and that's the individual behavior. Exposure to secondhand smoke in the home or at work, and that's the physical and built-in environmental, interpersonal, neighborhood, for example, levels of exposure to environmental toxin, and that's the physical and built environmental community. All right. Further influence of lung cancer mortality includes protective factors like engaging in early screening, and that's the healthcare system on the individual level. Access to high quality cancer treatment, and that's the healthcare system on the community level. State policy regarding Medicare coverage of lung cancer screening and treatment, and that's on the healthcare system on the societal. And state law regarding cigarette taxes and smoking bans, and that's the behavior society. All right. Dr. Carroll asked for her students in recent class to engage in a photo voice exercise where they went out and took photos of what cancer health equity looks like. Here is just an example of some equity, some of the examples. Equity was the goal for this assignment. It's hard to see, but in the bottom, there is a photo of a handicap sign. This is a perfect example of equity. Again, putting resources and effort where they are most needed. And today, in celebration of the National Minority Population Cancer Awareness Month, we're going to highlight some of the minority population in Minnesota and the work they're doing alongside the Masonic Cancer Center to achieve health equity. All right, the state of Minnesota had a total population of 6 million people. Minnesota remains a predominant white, but its non-white population has grown over the past 3 decades. It's about 24% today. Black individuals have been a large part of the growth, including a substantial immigration and refugee settlement from across the African continent. The increase in diversity is also seen in our students here at the university, with over 33% in the most recent incoming class identifying as Black, Hispanic, and African American and American Indian peoples.
Great, thank you, Julie, for that introduction. So I think Julie did a great job of really just giving us some context on cancer disparities and what health equity means to us by a definition and some pictures. I now want to get into some examples from some of my collaborators here at the Cancer Center, and I'll mention who they are, and we'll have a couple slides on each of their work that they're doing with and alongside some of our Minnesota communities. So the first slide I'm going to present on our slides from Dr. David Haynes. And we are going to talk about some of the work that he has been part of and leading with the breast cancer champions. And so meeting you where you live. And as you can see at the bottom, there are a lot of wonderful organizations involved in this particular effort. So in Minnesota, women of African heritage have an 8% higher mortality rate for breast cancer when we compare to women who identify as white. And what we also know is that women of African heritage are more likely to be to have a delay in breast cancer screening and be diagnosed with breast cancer at a later stage, which leads to more death due to breast cancer. And so this elevated death is due to delayed screenings, which could be caused by healthcare barriers, as well as very justifiable distrust in medical providers in the healthcare system due to past and contemporary treatment of African American or Black identifying persons in healthcare. And these are contributing to some of these differences that we see in mortality observed among African American women. So what is this group that came together doing to help? So the organizations came together to create breast cancer champions. And this was created from a community-based organization called Sisters Standing Up to Breast Cancer. What is provided in this is peer-to-peer education program that provides education and screening opportunities for women of African American heritage in the Twin Cities area. Trained community health educators of African heritage, or what they refer to as the champions, commit to being a recognizable source of information that the community can lean on and learn from. And of course, this overall goal is to reduce disparities in breast cancer among African descent women. So I just really like this slide from David. I love seeing the photo or two on the left that shows the folks involved in this effort and really leading this work. And the figure on the right shows the program overall, where the goal was to train the trainer curriculum or the champions And as you see, the heterogeneity and diverseness in their heritage there, from West African to African American, and then to go out into the community. And one of the really amazing things that was done, and what Dr. David Haynes contributed to, was a geospatial analysis of the impact of this program. So some of the outcomes, and I think this is remarkable and just shows what an amazing program this is, and the amazing champions these that are leading this program. Over nearly 4,000 women spoke with a champion about breast cancer. And 3,536 women were provided educational materials on breast cancer, and 202 women were screened. And I think that's just a tremendous success and really exciting. What's further exciting is this evaluation that was done on the program. And so they used some sophisticated geospatial analysis to see, okay, in areas where this program was offered, how was screening impacted versus areas that did not receive this program. And as you see in bold here, and in as demonstrated in the figure, there is a significant increase in screening among African American women residing within the area of the program. So that's just really exciting. I can't wait to hear more about how this program unfolds and the work that they're doing. Another population that actually was involved in that program, the Somali population, and one that we wanted to touch today, is the Somali population of Minnesota. So Minnesota is home to the country's largest Somali American population, and about 40% of everyone reporting Somali ancestry in the United States resides here in the state of Minnesota. And this is actually 4 times greater than the Somali American population in my home state, Ohio. So according to the state demographer's office, about 40% of Somali Americans were born in the United States. So what we wanted to do was showcase a really another remarkable study that's taking off. And this is a study that is being led by Dr. Ivan Wu. And the goal of this study is really some nice formative work, doing some qualitative data collection to get an understanding of what direction to go in for promoting cancer prevention within Minnesota's Somali community. And as you'll see, they're also using a very similar model where engaging with community health workers as these champions. So I think that is a trend that we're seeing that just shows the role of engaging with the community and using the community champions to really lead these efforts. So a little more background on our Somali community in Minnesota. There is limited data on immigrant and refugee groups. Now, certainly, the Cancer Center is working hard to contribute to more data. And data is just really powerful for us to understand what can we do more, what have we been doing great at, and how we can improve. And so I think this is exciting to work that Dr. Ivan Wu is taking on with alongside the Somali population. So what we do know is that generally cancer rates tend to be low in the Somali population. And what we also know is that there are several barriers to screening. And so these are contributing to the low cancer screening rates, like stigma, distrust in the healthcare system, for example. So Dr. Ivan Wu, together with some of his collaborators at the Metro Youth Diversion Center, got together and are working on this pilot project. And as you see, it really, I think, reflects listening to community voices and hearing where they want to go. So the first aim of this partnership is to conduct some focus groups to really get a good understanding of attitudes and thoughts and beliefs around cancer-related attitudes. Then they're going to do another set of interviews to further understand this data among individuals who are in either providing professional care or what are considered health workers that are in the community. And then the goal is to develop a workshop that increases capacity for those champions or those community health workers to promote cancer prevention. So very similar model that was used in the work that Dr. David Haynes evaluated. Okay, and we'll have to stay tuned to see the results and where that leads them. I think it's going to be really exciting. So another population that we really wanted to emphasize and mention some of the strengths today on what they're doing is the Hmong population. So today there are more than almost 70,000 people who identify as Hmong in Minnesota. And the Twin Cities Metro is home to the largest concentration of Hmong people in the United States. I think many people really learned about Suni Lee during the most recent Olympics and the pride that she was able to bring back to the Hmong community for being just a stellar gymnast. So a little bit of background, and these slides are shared by a colleague of mine, Dr. April Wilhelm. So the human papilloma virus, or abbreviated commonly as HPV, is a known cause for several cancers. And what we know is that completion rates for the HPV vaccine can be low among Hmong American adolescents and young adults. And we know this is one approach to prevention of several of these cancers. And so some of the background that went into some of the work that April's now doing is there was a development of a culturally tailored website and materials to support education and the ultimate goal of vaccine uptake. And this was a program that was developed through some community-based participatory research. And I'll mention in a slide who those partners were. And it created an educational website that was piloted and showed some really nice results. And the website, you can actually log into it. I checked it out the other day, Hmong promoting vaccines. So the website uses culturally tailored information. So worked with data from those focus groups. So got an understanding of what people thought about HPV, what was their knowledge about the vaccine, and what would be viewed as a facilitator for getting the vaccine, and integrated it into a website and that was culturally tailored. And of course, in doing so, they provided that in Hmong and English, in English for Hmong and English families. And as you can see in the figure, it depicts what the website looks like. So some of the work that's been done was some pilot testing of this, and it showed some really promising results with 30 children parent dyads that use and access the website. So what this program did is that it increased parent and adolescents' knowledge about what HPV is and what the HPV vaccine is as well. It also increased people's self-efficacy or ability to think that, okay, I can go and get the HPV vaccine. There's not too many steps involved, and these are the steps. So I feel pretty confident in that process. And there was a high use of that website, which is great. So Dr. April Wilhelm and her group now are working to essentially look at some different ways to disseminate this. And the community partners I want to mention are Shalamo and the Minnesota Department of Health that have been working on this program. And now April is joining them on this pilot to evaluate how best to disseminate this program. And so again, I think this is just another really wonderful example of some just great work that's being done in community, and we'll have to stay tuned to see the results. Oh, I forgot about this slide. So this actually shows you some of the dissemination materials. So there's a website, and then this is a version of the handouts, really encouraging and promoting knowledge around the HPV vaccine, just for your reference. Okay. The next session of slides that we're going to get on to is with our a focus on the tribal nations as well as the urban American Indian communities in Minnesota. So there are, as you can see by the map, tribal nations that reside in present-day Minnesota. We also have a considerable number, about 50% of individuals that identify as American Indian reside in urban Twin Cities area. And this is actually a mural on the right, which is outside of Minneapolis's Little Earth. of United Tribes, which is the only federally subsidized housing project for Native Americans. And I just really love the artwork and the culture shown in those murals. All right, so we're going to talk through actually two separate partnerships, collaborations. And the first one is with some of the work that Dr. Abby Bignot has done closely alongside the Native American Community Clinic, which is in the Twin Cities area and commonly referred to as NAC. So with this particular collaboration, what is known in the rationale for the work is that the annual low-dose chest CT is recommended since the year of 2013 for older individuals who have smoked cigarettes. However, what we know is that uptake is just poor overall. And what we also know is that our American Indian population in Minnesota suffers tragically from very high rates of lung cancer. And so Dr. Abby Bignot set out with her community partner to really understand beliefs and attitudes towards lung cancer screening and how to promote lung cancer screening among American Indian persons. So this is an established relationship with a clinic, and what they wanted to do was to develop really this research plan and the protocol together. So a good example of engaging the community, doing research with the community and not on the community. So similar to some of our other projects is that they started with focus groups. And focus groups, as I've alluded to, are a really great way of getting formative data and really to inform directions that are using the voices of the community. And so they did several focus groups, and they also did some key informant interviews with healthcare professionals. So the folks that would really be helping to facilitate the lung cancer screening. That's really helpful because you can look at both the patient perspective of, what's going to promote or facilitate or what are barriers, but also the folks day-to-day seeing these patients and working within their clinic workflows to understand their perceptions of facilitators and barriers. And what I'll show is that they learned a lot of really valuable recommendations from this qualitative work. And they actually, what they also learned from it was the value of having really tailored and engaging resources for improving guidelines on whether or not people should be screened for lung cancer. And we'll show you that in a slide. So here are the several recommendations, and I believe this just was accepted for publication. And I think in general, what you'll see from these recommendations is that it certainly could be helpful for other American Indian serving clinics, and certainly even other clinics that are seeking to improve lung cancer screening. So develop and utilize culturally tailored and appealing multimedia and educational materials. I think we can all relate to a dusty brochure in the doctor's office that's not very engaging, and just the value of really eliciting ideas around how to make that material more engaging to the various communities. Using incentives to motivate lung cancer screening and other services. I think another value is this idea of patient support and advocacy. So very similar to like the champions and the community health workers in the prior studies, but having folks that they can go to that really help navigate the process of learning about lung cancer screening and knowing where to go. So this work helped inform a lung cancer screening tailored brochure that Dr. Abby Bignot, the Native American Community Clinic, and the American Indian Cancer Foundation worked on. And I think it just illustrates bringing in the rich culture of the American Indian community into this brochure. And one of the nice things is that I thought I had a slide on is it really shows folks when are they not eligible for lung cancer screening. Very, very simple and kind of nice way to follow, like, do you currently smoke? how much do you smoke? And so people can go through this guideline to determine whether or not they should be screened, because that's kind of half the battle, is making sure that people get access to the right information so they know whether or not to act on it. Okay, this last program that is going to be covered is actually one that I have the honor of leading and collaborating with, and I'm going to actually turn it over to Julie to give us a synopsis of what we've been doing.
Well, thank you so much, Dana. Well, the internal funds from Masonic Cancer Center, led again Dr. Carroll, ability to respond to tribal needs to develop a smoking cessation program for their clinics, and result in smoking cessation program booklet on the left of the screen, as you can see on the screen. One on the tips and the strategies for quitting smoking, and another on how to reclaim traditional tobacco, which is a protective factor against commercial use of tobacco. Again, these funds also allowed for a relationship to grow with the tribes that has continued through additional funding. All right, this additional funding from NIH led to in-depth interviews with American Indian persons who smoke, and this infographic on your left, on your right, which is an asset-based approach for promoting quitting smoking. As you can see in the bubble, some examples of protective factors include providing access to traditional tobacco and promoting healing from trauma and grief as part of the quitting journey. All right. As you can see, this work is leading to additional smoking cessation program designed for American Indian people, including a smartphone app and a text-based program. I work with Dr. Carroll on the top study, testing the new app for smoking cessation among American Indian persons, and helping the research team with some of the day-to-day activities of the participant interactions. I have also been working with Dr. Carroll and her community partners and on another qualitative research. I have recruited participants here and in California who identify as American Indian and smoke, and have asked them their thoughts and ideas about various quitting smoking medication and some more novel approach. The goal of this study is that we can use the finding to better serve the American Indian persons in quitting smoking.
Thanks, Julie. That was a great overview, and that actually wraps up some of the examples of work being done to tackle cancer disparities in the state of Minnesota. What we wanted to do, given just the style of today, is to see if anybody had additional notable populations in Minnesota that they wanted to share on, or efforts that you know that is ongoing with any community partners to address cancer. And so, Amna, can we have them submit in the Q&A? Is that the best way to have folks share?
Yes, typically, and then I actually see one participant has their hand raised, so I
Great.
actually just go ahead and unmute them. Give me one moment. Okay.
Great. And I apologize, I can't see who has their hand raised. Oh, is it Marley?
Yep. So I
Yes,
think you can go ahead
hi.
and speak. Hi.
Good afternoon. This is Marilee McGraw. Great presentation. I am wondering how people who are disabled, specifically deaf and hard of hearing, might be included in some of these efforts. And it's interesting, as with regardless of race and ethnicity, the intersectionality of multiple characteristics. But it is people who are deaf and hard of hearing, and I'm raising this question as a coda. My dad was deaf and my mom is hard of hearing, and I have deaf members in the family. And I know that there have been many obstacles. And so I am doing my best to raise that issue and advocate. I think that there is a long way to go, but I would love to hear any thoughts that you have. Thank you.
Yeah, wonderful. I really appreciate you sharing that. And I imagine that there are, like you mentioned, a lot of obstacles to receiving early screening, accessing care, prevention among those of hard hearing. I would love to take this back to the Cancer Center and some of the scholars I work with, just to see if there's any efforts that I'm unaware of with this very important priority population. I think it's really an important one to have on our radar. So I really appreciate that.
Sure. If possible, I would love to put my email in the box if you would like to connect. I'm a nurse by training and would love to work with you on that. Thank you.
Yeah, no, great. Yeah, we're always, I should say, really a lot of the projects that I shared in the heart of the Cancer Center is really to respond to the needs of our catchment area. So we're often, really interested in raising different focuses from, community members like yourself, and suggesting ways to work with populations and tackle cancer disparities. And one of the things, we have pilot funding for new partnerships that folks can apply for together. And I know Amna's group and the Office of Community Engagement and Outreach in general, one of the things that they help do is bringing the right people to the table. So we can see who is doing work in this space and get a conversation going.
That's fantastic. You just made my day. Thank you.
Yeah, thank you for being on. I appreciate it. Great. What are other notable populations?
Yeah, someone from the Breast Cancer Education Association's their community representative, and so they're just noting that they do education and research to the African American populations of women with partnerships with community clinics to conduct some of the mobile mammograms. So
Oh,
doing that.
Yeah, that's really super. I think the idea of like a mobile mammogram is so great. What the ideal would be is that we can be in community, and so that we don't require our communities to travel all the way to the Twin Cities. I will say this is a great opportunity for me to mention one of the newer initiatives is the Minnesota Cancer Clinical Trials Network. This is a network of clinics, oncology clinics, but typically have primary care affiliated with them throughout the state of Minnesota. And the goal of these clinics is to provide access to clinical trials for those that don't live right here in the Twin Cities or in the Rochester area. And I think it just demonstrates this idea of really breaking down this ivory tower that people often think of and resembles the university, and really serving the community by being where community members are. So just mention that as a really great initiative.
There's another comment about outreach to rural areas in general.
Yes, so just in general, I think, as I mentioned, the Minnesota Cancer Clinical Trials Network is able to respond to that question. So specifically, there's about, if I'm recalling, nearly 10 of the Minnesota Cancer Clinical Trials Network affiliated clinics are in rural areas. And the goal of those networks is to not just provide access to treatment trials, so treatment clinical trials, but also prevention. And so that's hopefully a great opportunity to, as that initiative continues, for more opportunity for research with rural communities. I do know we have the Cancer Center is really, and me personally, really interested in engaging and working with rural communities. There's a lot of barriers, as you can imagine, just traveling to get healthcare, transportation, and then just having lower health communications that tend to be in rural areas, and a lot of other obstacles. So I think the frontier of our work is really going to be trying to continue some of the work and work better with our rural communities to address cancer disparities. So great question.
You're getting some kudos. So Julie and Dr. Carroll, just on your presentation and just how appreciative folks are for the information that you've shared today. So Galen Richards, she's actually the Champions Coordinator. So the Breast Cancer Champions project you all heard about today. Her and Dr. Haynes are continuing to explore replicating this model in other communities with some unequal burdens of breast cancer, and then other cancers as well that are experienced by women of African heritage.
That is just wonderful to hear. I think hearing about just like the sustainability of these projects and the ongoing work that I know takes, so it sounds like there's somebody online that's really a champion and specifically in that program, the work you do is just amazing. And I just kudos to you for continuing and sustaining that work. It's really exciting that the evaluation of that work that showed the promise of the Champions program. So kudos to you and all of the work that you do.
I don't see anything else in terms of
Okay.
any suggestions on other populations.
Yeah. Great. Well, you know, I think one of the, we have a couple more slides, but if there's anything that comes up, and, you know, I appreciate the sharing on persons with disabilities and hard of hearing. I think it's really important that we listen to our community and hear about their needs and their requests versus just like imposing what we want to do. So please always feel free to share that. And thank you again for sharing those thoughts with us. So just a couple more slides. I did want to do a selfish self-promotion here. I do teach a class that I thought that this group could be interested in. It's a course that happens in the spring. And really my goal is to have the students walk out feeling that model that Julie presented, understanding that it's not just the individual and the biology, although that can play a role, but really the multi-level determinants. And then also, how do we move beyond just talking about disparities, but how do we really engage? Of course, there's no recipe, but what are some best practices for working with community, listening to community? What is cultural humility, and so forth. So if you're interested in more about that, please feel free to reach out to me. And of course, I want to, in addition to Julie, thank you so much for presenting with me. It's a joy to have students present along with you. I wanted to acknowledge some of my colleagues that shared their slides today. So you can see some here on the slide from Dr. David Haynes, Dr. Wilhelm, Dr. Wu, and Dr. Vigneault. So these are some of the folks that are, you know, really working alongside communities in an authentic way, and I admire the work they're doing. So with that, that's the end of our slide deck. I do know we reserved some time for some Q&A. So now would it be appropriate for me to stop sharing?
Yep.
Okay. How do I do that? Okay.
Perfect. And so I say this every fireside chat. It is not a fireside chat without a fire. And I'm going to go ahead and get that started. Okay. So thank you so much, Dr. Carroll and Julie, for such a wonderful presentation and for sharing some of the incredible work that is being done in collaboration with some of our unique community minority populations in our state, and for the robust discussion. So thank you for that. So as Dr. Carroll said, we're now going to transition to our Q&A. So this is an open conversation. And so feel free to submit your comments, questions, et cetera, in the Q&A. We'll try to address them in the time that we have now. So we have quite a few questions that were submitted. So we'll just go ahead and start with some of those. So I will just kind of ask this question, and Dr. Carroll, Julie, feel free to both chip in. So what barriers do you two face as researchers working in community when it comes to approaching communities that have distrust in the healthcare system?
Yeah, that's a really great question. And I think I always want to start off with the context that, in related to the class I mentioned, and something I always hope that my students walk away with is the term distrust, which implies that it's very justifiable concerns with the healthcare, with the university, with research, due to how folks have been and currently still continue to be maltreated. So I just wanted to make that clear. So I understand I represent a university and I represent the research. I also identify as a white female. And I know that that is my positionality, and rightfully so. There is going to be hesitation and some communities that just might choose not to participate in research at that time. Overall, I have found that having inroads through ongoing relationships or a project I have that leads to other projects, other research, really opens the door to other community partners, has been, quite successful. So I think at the end of the day, it's really just kind of humbling oneself, and something I reflect on a lot is you go through your whole training where you're the expert and you're supposed to be the expert. The one thing that I try best to do in community is recognize they are the experts. This community has the knowledge. They have the history with the health problem. It's my honor to have a seat at this table, and it's a privilege to be at that table. And so making sure that I really honor and recognize the voices of my community partners, the community first. And I think if we just learn to sit and shut up at times, that's the best. And just to really listen to the voices, listen to the history. And, I think when we do that, people learn to trust you and continue. Julie, I know you've been doing some of this work with me. What further would you like to add?
I think just adding on to the distrust, I've seen that a lot, like just directly working with the participant. And one issue that has been raised is based off of the historic trauma and the research that has been conducted in the past. This participant seemed to be hesitant. And most of the questions that were raised was, how sure am I that whatever perspective that I'm sharing or the idea that I'm sharing, that the research that I'm contributing to will come back to benefit the community. So just like hearing like the participants' issues, and it's like they have the right to raise those type of barriers and close in, and it's just like being able to assure them and just showing them like its actions again are better than words. So basically just showing them that the work that we're doing actually does go back to the community and benefits in the community, both on the intellectual level and on the individual and on the community level. It just helps them a lot.
I love that. Thank you both for sharing that. And Dr. Carroll, do you have something to add?
No, Julie
That was
summarized it well.
Yes, I agree. And so also just kind of really speaking to, you're not doing research on communities, it's with communities. So having that collaboration, that bi-directional relationship building, and that trust is so important. So thank you both for sharing that, and just for the efforts that you put in to the work that you do. So another question we had is, so do you think we're ever going to eliminate disparities completely? I know this is a really big question. It might be challenging to try to answer in the moments that we have. But how close can we get and how do we achieve this? I know you touched a little bit on this, but do you ever think we're going to get there?
Yeah, I hope, and I think that we have to stay oriented that way to maintain progress. I think that one way to achieve that is this idea of health equity. And as Julie mentioned, like the handicap parking sign is a perfect example, I think. And a student that brought to me, and I thought, wow, I think sometimes we hear the word equity and it's thousands of different definitions, but this is a perfect example where you're not trying to harm any community, but what you're trying to do is put more resources where they're needed. So more efforts and more resources with the communities that have suffered disproportionately from cancer is where our efforts need to go. And I think this is best embodied by a lot of the work we have done to date has not been engaged with community. It hasn't been authentically done in partnership. And because of that, a lot of our interventions, policies, approaches are beneficial to the white urban population. And it unintentionally leaves behind populations that already are suffering. So we continue to benefit the populations that are doing better, and we continue to leave behind the populations that have been suffering. So to me, really moving forward, and I hope today was a good demonstration of some of the work that's going on in this space, is building those relationships, listening to communities on what they want to focus on, getting the right people at the table that can work with those communities, and really putting our efforts there. So, I mean, ideally, we would completely have equity for everyone. And then once we have equity, then we can have equality.
I just thought about that image that I'm sure you share in your courses and that most people in this space have seen with the baseball field and the fence. And so that's literally what came to mind when you were just speaking. So
yeah, and like I always think too, you know, justice is really, you know, and so what Anna's describing is there's three people behind a fence of different heights. And the taller person, which in this example, we could say is the folks that are more privileged in this world, can see right over the fence and see the baseball game. Whereas there's somebody that is maybe less tall and can't see. And then I would even suggest that there is a population that we have discriminated, structural racism has hit so hard that the ground's even dug in and they're pushed down. Yet they're so resilient and they're there. And so the ideal would be that, okay, we already have the tall people seen, the other folks need different boosts, and that would be equity.
Mm-hmm.
And then one day, if we keep doing this work, we can actually take down the policies and the systems in place that caused the differential in the first place, which would be the fence. So that would be the long-term goal. And I think, you know, I tend to be a coffee mug half full type of person. So I like to think that that's possible.
great. And Julie, do you have anything to add?
No, Dana summed it up. Well said.
I agree. Thank you. So we have a few more questions. So when it comes to just comparing the US with our state, how does Minnesota compare to other states in the US in regards to disparities?
Yeah, that's a really, really great question. I probably won't fully be able to answer that right now, but definitely if that person wants to follow up. One of the things I reflect on a lot is in many states, cardiovascular disease is actually a top killer. In Minnesota, we are not far behind on that, but actually cancer is our number one, and at least in some of the most recent data. So that's unique. I think we certainly have our disparities in Minnesota, given that the privileged and the healthier can be quite healthy, and our minority populations again suffer. And so while the rates in our minority populations might not necessarily be higher than other states, the disparity can be a lot more stark because our, for example, white population has been privileged more, right? So that disparity gap is even broader. I know in Minnesota, we certainly have our handful of unique cancers that are of concern to our catchment area. Definitely lung cancer tends to be, we're high on the map with lung cancer. And that's been a big reason for a lot of the work that I've done with in my time here in Minnesota, and that Julie's been a part of. We also have some other unique environmental exposures that can contribute to that beyond smoking. So radon is of notable concern in Minnesota, and actually radon, which is a natural occurring gas, can synergistically work together with smoking to cause higher lung cancer. And so that is a problem for Minnesota. And I know we have some other environmental exposures as well that can contribute to a differential cancer burden. But again, I don't have those off the top of my head, and happy to dig them up in another presentation that we just didn't have enough time for today.
Well, thank you for that. So we are running out of time. So I'm going to ask just one question to you both. What are final takeaways that our audience should take from your presentation today? And then also, what can everyone on this call do to advance health equity? Give you each 30 seconds.
No big feat. I think just what was showcased today was I love the individual that stood up and provided input on a direction that the Cancer Center could consider. The goal is that we're very bi-directional. So we at the Cancer Center do research, and the goal would be to really respond to the community needs. And so we always are seeking out community involvement, community voices. So please just, I think, keep up with that, keep speaking up. That's what I would leave with. Julie?
Yeah, for me, I attended an event, I think last week. It's the Red Dress. It was an event hosted by Dana again. And someone said that poor policy leads to poor health. So just in general, like putting in effort to like drive better policy. And I think that's definitely going to get us closer to, health equity and better health. So just, yeah.
Great. Yeah. Those are great. Thank you both for sharing those. And so we are out of time. So we're going to have to leave it here. I know we could probably keep you both for even longer. So Julie and Dr. Carroll, thank you so much for your time today and for all of the incredible work that you two are doing to advance health equity in our state. So after today's session ends, you will all be receiving, Zoom actually will populate a window to complete a quick survey for us. So we would really appreciate if you could spend just a few moments to provide us with your thoughts and feedback about today's session, because it really does help us improve our future programs. And then after completing the survey, you can enter a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And then everyone who tuned in today, and unfortunately excluding University of Minnesota affiliated staff, faculty, and students, will be entered into a drawing to win a $25 e-gift card. So keep an eye on your email, because two lucky winners, two lucky attendees are going to be winning a $25 gift card. And join us for our next fireside chat in June. We're taking a little break in May, but join us for our fireside chat in June on June 15th from 3 to 4 in recognition of acute myeloid leukemia. We are taking the month of May off, but May is Skin Cancer and Melanoma Awareness Month. So please tune into our fireside chat from last year posted on the Masonic Cancer Center's YouTube page to learn more about some sun safety tips and how to protect yourself and your loved ones as we approach our summer months. And lastly, make sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on future announcements and events from the Office of Community Outreach and Engagement. Thank you everyone for tuning in. We really, really appreciate it and hope to see you all soon. Thank you, Dr. Carroll. Thank you, Julie, once again. Have a good rest of your day. Bye now.